Greetings, welcome to this second video on the walkthrough of USMLE-like question. Obviously, these aren't actual USMLE or NBME questions, they are copyrighted, so based on my experience, I wrote my own questions and drew my own diagrams and illustrations. So, if you find a mistake with some of the questions, please let me know. Now you know why it's there, because I wrote them myself. And if this is your first time in my channel, I usually make medical review videos both for USMLE and for med school in general. So, without further ado, let's go for our second question here. So, a 32-year-old black female patient comes to the consultation with a complaint of worsening exertional dyspnea for 4 months and a new rash on her face. She takes no medications and used to run twice a week, but has had difficulty lately. She has never smoked and denies having fever lately. Her temperature is 37 Celsius degrees, pulse is 58 per minute, blood pressure is 146 per 92 millimeters of mercury, respirations are 16 per minute, and oxygen saturation is 98% on room air. Clinical examination reveals wheezing on pulmonary auscultation. A chest CT is ordered and reveals lymphadenopathy. The patient agrees to undergo a spirometry and a lymph node biopsy. Upon biopsy of a mediastinal lymph node, the following is seen. Which of the following was most likely seen on her spirometry? So, here we have a traditional question where you have an image and some graphs, and it wants you to find what the description and the image represent which disease, and then what would be found in these diseases. And so here it's asking specifically about a spirometry. So we already know it's most likely a respiratory disease. And so here, if you can understand the image, we are seeing a granuloma here. You can see there is a huge cell right here in the middle, but it has many nuclei, and it's surrounded by epithelioid cells. And then around the epithelioid cells, we have many lymphocytes. So we can identify this as a granuloma, but as you can see, there is no necrosis in the middle. So there is no caseation necrosis. This is a non-caseating granuloma. Now, there are other possible causes of non-caseating granulomas, but they are traditionally linked to sarcoidosis. And sarcoidosis is most often found among 30-something-year-old black patients and female patients. So we here have the prototype of a sarcoidosis patient. We have a black female with 32-year-old. The most common complaint is respiratory. It usually presents as cough or dyspnea. So here we do have exertional dyspnea. And it will sometimes present also with constitutional symptoms, such as, for example, fever, tiredness, malaise, but these pretty much are in specific, this won't target the disease. But we have the respiratory complaint of exertional dyspnea, and we have a biopsy showing a non-caseating granuloma. So this is strongly pointing towards sarcoidosis. And we also here have a new rash on her face. So a rash could be perhaps understood as lupus, for example, but there are some other things that also cause a rash on the cheeks and on the nose. And one of them is sarcoidosis. There is an extremely characteristic lesion for sarcoidosis, which is somewhat close to lupus, and is thus called lupus pernio. Lupus pernio does not have anything to do with lupus except looking somewhat similar to it, and it's actually a dermatological manifestation of sarcoidosis. So, of course, it has to do with the granulomas, and we have an extremely characteristic description here. The very same patient and ethnicity we would expect, the correct age, and we have respiratory symptoms, dyspnea, and a new rash on her face, lupus pernio. She doesn't smoke, she hasn't had fever lately. She could perhaps have fever from sarcoidosis, but the fact we know she doesn't have fever also speaks against something like tuberculosis, for example. Although in this patient we already have the non-caseating granuloma, so we would immediately think about sarcoidosis. In a test, a non-caseating granuloma is most likely going to mean sarcoidosis. She is slightly hypertensive here, but overall her vital signs are normal. She has a somewhat low pulse, but we've heard here that she runs twice a week, so okay, she is somewhat athletic, doesn't mean anything for us at this moment. HSCT was ordered, revealed lymphadenopathy, and this is somewhat what pretty much closes our diagnosis. Of course, we've won the biopsy, but we have a patient with respiratory symptoms, with lupus pernio that presents with mediastinal lymphadenopathy. So this is pretty much characteristic, this is pretty much showing itself as sarcoidosis. And then the patient underwent the lymph node biopsy, we have the result here, and a spirometry. And then what actually wants to know here is, 1, do you know what to expect in terms of obstructive pattern, restrictive pattern in a patient with sarcoidosis? And 2, do you know how to interpret a simple spirometry? And so, what would we expect from let's see, if you want to do the question by yourself here, you can look it now. I'm not going to stop the video just before the diagrams, because there's pretty much no way of reading the diagrams without giving away the answer. So, with sarcoidosis, we are going to expect a restrictive pattern. Sarcoidosis can evolve with lung fibrosis. It's the late stage of sarcoidosis. So what we're going to expect is a restrictive pattern. The lung will have lower volumes, but it will have no problem in breathing air in or out. You have no specific obstruction. It's just as a whole somewhat fibrosed, so you have less space in your lungs. And so we know that sarcoidosis is going to present with a restrictive pattern. And now here what I want you to know about you is, do you know how to recognize a restrictive pattern on a spirometry? And so here on A you have a patient that has a total lung capacity around 6 liters. Okay, no problem here. And the flow is reaching 8 liters per second here on inspiration, and then a bit more, around 5 or 6 on expiration. Okay, the values don't matter as much as the shape of the curve. And so here we also have a vital capacity around 4 liters, slightly larger. We have here it starting slightly before 2 liters and ending in 6 liters. We have a total lung capacity of 6 and a vital capacity around 4.5 liters. And well, this is on the upper limit of normal, but we have here a patient that runs, or at least uses to run every week, so perhaps this will be normal for her. So this will be the normal spirometry. This is exactly what we would expect from a healthy patient. On B here we can see, however, that we have a different shape. And first, if you don't really know what you're looking at in a graph, in a diagram, try to interpret it. Look, okay, what can I bring out of this? What does these values mean? So for example, okay, here, volume. Volume, 8 liters. So 8 liters is the most it's reaching. So what can 8 liters mean? Well, it's most likely the total lung capacity because it's the largest volume the lung reaches. So we have an increased total lung capacity here. On the other hand, you could see here, for example, okay, what's the smallest volume the lung reaches here? It's about 3.2 liters perhaps, maybe 3.5 liters. So you can see that you have an increased residual volume here. You have an increased total lung capacity and an increased residual volume. And besides, you can see that the flow curve here on expiration is looking somewhat weird here. It's compressed. The flow on expiration is slower than it should be. You can see that the flow is lower. You're not even reaching 4 liters per second on expiration. So you have an enlarged lung with more residual volume, with greater residual volume, and with difficulty in expiring, with a reduced outward flow. So this is an obstructive pattern, which is what we would see, for example, in COPD. Then we have C here, and you can see that your total lung capacity is decreased. Now it's less than 4 liters, and you also have a decreased residual volume. Now it's about half a liter. Meanwhile, the flow curve looks pretty much normal. You don't have any significant decrease in flow. So if flow is normal, it's most likely not obstructive. Meanwhile, if you have a smaller volume, a smaller total lung capacity, a smaller vital capacity, which here is looking like 1.5 liters, is the amount that's going out and then coming in. If all these volumes are decreased, then it's probably because your lung is having a difficulty increasing. So you have a restrictive pattern. And so here we have what we're looking for. Our answer here is C. We have in sarcoidosis a restrictive pattern, which is being shown on the spirometry by decreased total lung capacity, decreased residual volume, and decreased vital capacity, but pretty much normal flow. Then, just for the sake of completion, on C we have a quite weird looking curve in which you can see that the flow doesn't really vary a lot. You don't have a increase in expiration in the 4 seconds. What you would expect from most curves is that it starts fast when you are expiring, and then it slows a bit, it tapers off a bit. Here on C, that's not what you see, it's pretty much constant. So that's what you expect if you have a fixed airway obstruction. For example, if you have a tumor that's pretty much uniformly restricting inspiration and expiration. And here in G, you have a curve that's completely meaningless. Because I invented this one. Sometimes you will find on some tests some answers or some curves, some names that you look and go like, wow, this is really weird, I've never seen this one. I'm going to pick this one. This is usually a poor idea. I've made up this curve, this doesn't exist, I invented this one, and it's absolutely meaningless. I'm pretty sure this doesn't represent any possible complication, any possible disease. So the lesson to learn with this E alternative here is, if you see something you've never seen before, that's most likely not the right answer. And so we come here, our correct answer is C, is a restrictive pattern found in sarcoidosis. Thank you for choosing to spend your time with me. I hope this has been useful. This is not medical advice, this is just a commentated resolution of a question. And if you are interested in these questions, make sure to subscribe because I already have the next one on its way. Thank you once more for choosing to spend your time with me, and I hope to see you on the next video.